Awesome. Thanks, Ash. Thanks to all of our supporters. We appreciate all your help doing this journal club. We've got a great journal club. I say that every time. Ashley, you know what number it is? Phil's not here to ask. You're on mute or something. I can't hear you now.
36.
Did you say 36? You look like she said 33.
I said
36. 36. Yeah. Yeah.
Mhm.
So I'm Rob Manske from Wichita State University and Ascension Via Christi in Wichita, Kansas. Thanks everybody for joining. Barb, you want to introduce yourself and then we'll get to Dr. Key in just a minute.
Sure. I'm Barb Hoogenboom, and I hail from Grand Rapids, Michigan. But my other job is that I am the editor-in-chief of IJSPT. And again, it's super great to have everybody here, especially Dr. Key. Thanks for coming, and we expect all great learning as we always have. So thank you.
All right. Thanks, Barb. I was gonna have Mike introduce stuff, but he hopped off. So he hopped off. We're waiting for Phil
He
to
just
get on. This
went
is
away.
it's like a chaos in here right now this morning or this afternoon. So we want to welcome
Like a revolving
our
door.
first guest, our only guest tonight, Dr. Key. Thank you, Dr. Key, for coming. I'm going to tell you everybody a little bit about Dr. Key. I'm going to try to abbreviate this because I could be talking for 5 minutes with all of his accolades. Dr. Key is a distinguished orthopedic surgeon and associate professor at the University of Kansas Health System. He has a comprehensive background in sports medicine. He serves as the medical director and head team physician for the Kansas City Royals. Go Royals! A role he has held since 2011. Dr. Key earned his medical degree from the University of Oklahoma College of Medicine, completed his orthopedic surgery residency at Martin Luther King Charles Drew Medical Center in Los Angeles. I didn't know that. Followed by a sports medicine fellowship at the University of Cincinnati Sports Medicine Center. Dr. Key does I didn't realize he did knee replacements, but he does a little bit of everything. And he was telling Ashley he talks to Dr. Bird about hip problems and everything. So he's like he's kind of a Renaissance man. He sees a little bit of everything. I thought he was mainly elbows from his articles he sent us, elbows, shoulders, and knees, but he does a little bit of everything. He's dedicated to education and mentorship. His dedication to education and mentorship is evident through his involvement in mentoring programs for medical students, residents, as well as his leadership in sports medicine training programs. Contributes to the advancement of orthopedic sports medicine through ongoing research, clinical practice, and community outreach. Thank you so much, Dr. Key. I know you did this kind of short notice. I asked you not long ago, and you just emphatically said you would be happy to do it. So we appreciate you joining us tonight, and we look forward to talking to you. Is there anything more you feel like you need to say about your history, or anything I left out on your bio that you want to tell us about?
No, Rob, thanks. I'm
Not at
I'm
all.
humbled. I'm humbled. I tell people I just do what I do. I am kind of a renaissance man because I tell people what I don't do. I don't do hip replacements and I don't do spine. Everything else
Very
it
good.
is pretty much in play.
Yeah.
That was evident from today. I just came from the OR, so I was doing 3 knee replacements, and a day ago I did 2 ACLs, and then I did a UCL reconstruction and rotator cuff repair. So I do a little bit of everything. It keeps me good up here. So
Awesome.
thank you guys for having me. I wouldn't miss this because it's times that, it's really important between uh, the physician and the therapist, to really be hand in hand in terms of doing what's best for the patient or the athlete or just in general. So I really appreciate the opportunity.
No, you're welcome. I can vouch for Dr. Key. I don't see that many patients of his because I'm in Wichita, but it wasn't that long ago. I had a patient that you did a UCL reconstruction on, and I think the patient gave me your number, and I just texted you to see if there's any way you would be willing to talk to me, and you literally called me like right back, and we had a good discussion about him. He's just a very PT friendly physician that you can count on anytime. Hey, Phil. Phil's on. Dr. Key, this is Phil Page.
Hey,
Hi,
Phil.
Phil.
Hey everybody. Hey Dr. Key. Sorry the power went out down here and I had to reboot everything.
Is
So
it still out? It looks a little dark behind you. Is it still out or are you?
no, it came back
No.
on.
Okay, good. Good.
I'm a vampire.
I think it was the jambalaya, Phil. Looked
There
like
was
that
That's what we
crawfish
were
jambalaya.
wondering,
etouffee.
yeah.
Crawfish
Yeah.
etouffee.
Crawfish etouffee. That looked good, Phil. It really looked good. So, Dr. Key, tell us before we get into the articles of yours, who did you do most of your training with? What surgeon did you spend most of your time training with?
Oh, geez. Well, here's the thing. Being in LA, we rotated over to Curlin Job Clinic. So I was actually the last resident to work with Dr. Job before he
Awesome.
retired.
Oh,
And
wow.
so he was one of my mentors. Clarence Shields was another one of my mentors. Um, Neil Elatraj was my staff, which is funny now because he's kind of my colleague, which is weird. Um, so, but a lot of those guys in Cincinnati, I spent a lot of time with Dr. Height, Dr. Colosimo, Dr. Krimchek, I spent a little bit of time with. So, I think I've built a solid network, I think, of people that I could bend their ear. When Dr. Yoakum was still alive, um, he was one that I really leaned on when I first started taking care of the Royals because, it's daunting not only taking care of one a major league club, but the entire entity, 7
Mhm.
teams. And
Yeah.
he was very valuable. Dr. Andrews was very valuable. Um, Dr. Bird was very valuable. So I had a good network of individuals that I could call and that were more than willing to pick up the phone and talk. So
Yeah.
I think that's extremely important.
Yeah, some great surgeons you're talking about there, and we have a very similar kind of very similar network, within the physical therapy field as well. So it does
Yeah.
all of us great.
Yeah,
So
it's
yes, go
great. I
ahead.
mean, Dr. Meister is my best friend in baseball. So, it's just like, we're brothers from another mother. That's what we always say to each
There
other.
you go. That's
Oh,
Phil.
Lord.
That's Phil and
Oh,
I.
Lord.
That's
Yeah.
Phil and
Yeah.
I. Phil, how many times have I told you that? Too many to count. I'm sure
Yeah.
I
Too
will
many
be.
times, Big Rob.
I remember
Too
working
many
with
times.
Keith when he was a fellow.
Oh, there.
So,
Well, yeah.
down in Florida.
Yeah, down in Florida. Yep.
So, Dr. Key, tell us why you I mean, you picked you wrote one of these articles, or I guess you were the senior author here on one of these one of the articles on ulnar collateral ligament reconstruction. What is it? Is it the fact that you see so many? Is that why you seem to appreciate and like treating UCL injuries, or what is it that kind of piques your interest and drives you to treating them?
Well, I think the big thing is obviously by taking care of a Major League Baseball team, you're going to see it.
No doubt.
You have no
Mhm.
choice. You're going to see it. And whether it's shoulders, but the question then becomes, kids are getting it at younger and younger ages, unfortunately.
Yep.
And then there's times where you see kids that got it, you're really saying, did they really need it or did they not?
Mhm.
And so I think, ultimately, um, we're seeing it more and more. Kids are throwing more and more. They're playing more and more games. It just piqued my interest. And I used to listen to Dr. Job a lot, following him around in clinic, talking about uh, working on kinetic chain, things of that nature. Um, so I think that once I got into it and doing the reconstructions, then the question was, how long do they last? We talk about in the industry, they last about 5 to 7 years, you know, um, and can you do something or look at something and make it better? And that's why when I saw the article from Dr. Camp, I was actually taking my daughter down. She goes to LSU, and I was taking her down, and I called him. I said, "Hey man, you stole my thunder," because what he wrote in the article is pretty much the same um, technique that I use. It's a little bit different, but it's the same. And can we get a longer lasting reconstruction? And so, those are the things that pique my interest and seeing and being able to get guys back a little bit quicker. We talk about 12 to 14 months, um, and can we get them back in 10? It used to be way back when you could get them back in 10, but now people pushed it out a little bit longer. It's just like ACLs. People say, "Oh, it's going to
Yep.
be a year," which I don't believe in, but that's another discussion.
So that's another journal club.
That's
get you
another
back.
journal club
We'll get
because
you
I
back
have
for that
strong
one.
feelings about that. But yeah, just those type of things really pique my interest. So
Yeah, yeah. And these, you know, the patients that have this are, you know, especially your ball players and the high school players, college players. They're some of the most motivated patients that you can have, you know, to get back. I mean, they don't screw around at all. They're like totally serious and really, you don't have to push them very hard. They're like pushing themselves. At least the patients I see are pushing themselves. They really make our job easy, and a lot of the times they do fantastic. So let's talk about the first article then. Are you okay if we do your article first, Dr. Key?
yeah, we can do my
Okay.
article first. That's
All
fine.
right. So the title of the first article is Ulnar Collateral Ligament Reconstruction Utilizing the 3-strand Palmaris Tendon Autograft with a Hybrid Linear Construct. This was published in Arthroscopy Techniques this year, 2025. So this is a really recent, obviously relevant article. So the aim is to describe that technique. So Dr. Key, you said you had the video. Do you want to show the video now, or you want to wait a little bit later after we talk a little bit, or?
Well, I can show the video.
Okay.
All right, I'm gonna see if I can reproduce this. Now,
Yeah.
You
now
got
hold
it.
on now.
We
You got
it.
did it once.
You
You
got
can
it.
do it again.
I know. I know. We're gonna see what happens. We're gonna see what happens. All right.
Looky there.
So far,
Looky
so
there.
good. We're
All right. Here we go.
step in the right direction here. All right.
Lucky. Bingo.
Yeah, you got
Yes.
it. It's going. All right.
There we go. Yeah.
Yep, now it's moving. Yep.
All right. So Dr. Key, you narrate, tell us what's going on.
Yeah. So with this harvesting the Palmaris, you know, you can do whatever technique you want. I do kind of a 3 incision. I know Keith does this 1 incision and uses a tendon stripper. I tell him, I'm not doing that. It's just there's too many bad things around there. I said you can do that because you're Keith Meister. I'm not doing that. So I do 3 incisions and harvest it. The key to my technique is that I do a triple loop. I loop it back on itself. Okay, and that's what I'm doing here. So I'll keep going here. Now here, doing this is the most meticulous part, and is being very meticulous on the way that you suture this. And you'll see as we kind of go along here. So right there, I've done the one side that has all 3 of them. That's going to go into the ulna. The other 2 limbs are the ones that's going to go into the humerus. So
What's that? What's the size of that, Dr. Key? I can't tell from your picture. What
so
typically
the length of that is about 55. So you want it anywhere from about 50 to 60. Okay. And usually the total length of your Palmaris is usually about 170, 180. I had one of my Royals players that had a Palmaris that was 240. I was actually able to do a quadruple loop, but that,
Wow.
you know, that's a rainbow unicorn.
Yeah.
The other thing here is that I'm doing this with a Palmaris. You can do this with a gracilis as well. But sometimes I've even used semitendinosus when the gracilis wasn't very good. Now with the semi-T, you're not going to be able to do a triple loop. It's just too big. So a double loop is fine. So let me go back. I just want to show you this. This is what I've done. That's my smiley face. I've done that for 30 years. So everyone in the city knows my smiley face.
Oh, that's funny.
All right.
Love it.
That's the fascia. You'll see the line there of the flexor digitorum. Yeah. So this injury was more distal. He had like a high grade distal injury to his UCL. So I'm going down the dissection. The incision isn't very big. You know, we know who did surgeries by their incisions. Dr. Elatraj's incision is a mile long. Keith and I are pretty small. It doesn't matter how long the incision, as long as it's getting done. So we're just dissecting down and identifying the UCL. And then we're going to split the UCL here. Okay, so once we've done that, now this is another meticulous part of this. I basically take a tip and I have to center this onto the ulna so that I can get my drill tunnel right. Okay, and usually my drill tunnel is going to be anywhere from about 5.5 millimeters to maybe up to 7.5. I get a little antsy when they get to 7 and 7.5. So I'm going to drill this in. And then I use the reamer there. And with this, I check 5 times, I drill once. It's just like anything you do in this job. So we'll drill this tunnel about 20 millimeters. So there's my tunnel there onto the sublime tubercle. Here's the joint right here. Here's the ligament right here. And here's my tunnel. So
There it is.
So I dock it in with a screw. And that's my key right there. I can basically take this graft and pull the arm straight off the table. And if you can do that, you know that thing is wedged in there. So
what happens if it pulls out right then? You just get a bigger.
So
like, what do you do then?
What I do with that, I'll usually use a bigger size screw. I use usually a 4.75 screw. If it pulls out, I'll move up to a 5.5.
Gotcha.
Yeah. So then now I'm preparing on the humeral side. And the key here is I never transpose the nerve ever. You don't need to. I don't understand why people do it. Leave the nerve alone. It hadn't done anything to you. So what I do is dissect behind the nerve and I get onto the epicondyle. I just got through doing a revision from Dr. Andrews. I love Dr. Andrews, but I hate doing revisions of his because you have to find that damn nerve.
Yeah, he does it on just about everybody, doesn't he?
Yes.
So, Dr. Key, while this is going, if you can, how does doing 3 strands change the strength of the graft compared to other procedures?
Well, it's adding another strand because if you look at the docking technique is 2 strands, right?
So
it's a triangle.
Yeah.
It's a triangle. This is 3 strands every single time.
Does that add like how much more strength does that add?
It can add almost 75% probably.
Oh, nice.
So you can see how big this graft is.
Big.
So this is where it comes in, where I drill the tunnel and then I drill 2 tunnels in the tunnel. So you'll see when I drill these in, I'm drilling out the back. This is that little retractor I call the fickle finger. And then And you see how it sucks it into that graft. That thing is, and I tie it on the back end, in the back of the elbow. And it's so far back there that you don't, and it's so far back there that you usually don't. I have rarely gotten any ulnar nerve irritation of this. And then what I do is I take the native ligament and then I weave it into my reconstruction to add more collagen.
How do you do? Can you explain how you do that?
So you see how I think about it like a hot dog in a bun. The graft is the hot dog. The native ligament is the bun. So I just take the bun and just loop it over and then over the top.
Yeah.
And so you'll see here.
Oh yeah, you can see it. Yeah.
You can see it where I just tied in.
Yeah.
And that thing is tight as a tick.
Did you just say tight as a? Did you say tight as a tick?
I did.
I have never heard that.
That's awesome. A Kentucky thing. I'm from
You're
Kentucky.
not from the South, Rob.
No, I'm not.
I was gonna say it's a Southern thing.
You guys have heard of that? Tight as a tick. I've never heard that one.
Of course.
Yeah.
All the time, Rob, all the time.
Sorry, I'm going to use that
And
one.
I'm
Damn.
from Michigan.
Hey, don't attack me. I just never heard of it. I'm going to use it. I love it.
So
awesome. Awesome. That video was great. Thank you very much.
No, you're welcome.
So tell us, I think, I don't know this, but I'm guessing some of the people listening probably can't fully appreciate the difference between like anatomical and docking. And the next paper, we're going to talk about the docking procedure. So can you kind of describe the two of those for us?
So the docking procedure does 2 holes into the ulna, right? You have 2 holes coming in here and here. And then you're weaving the graft through, and then you're bringing it up to the humerus, and then you're docking it in there, right? So again, you have a triangle technique. You have a triangle structure. The structure that I do is straight linear. So, and here's what I'll say about my construct compared to others. I've done over 100 Royals players, okay, with this technique. I've been doing this for 15 years. I just hadn't published it.
So it's nothing new.
No, this is nothing new. I've been doing this for 15 years. That's why I'm getting yelled at by a few. Jeff Dugas was yelling at me about this. and he goes, "Why haven't you published this?" I said, "I don't have a paper mill like you." Right? I got a son now who's a first-year medical student. Yeah, I got a son that's a first-year medical student. He can help me now. I got in-house.
There you go. There you go.
But the thing is that I've done over 100 Royals players. I've had 2 failures. I've done 300 outside of professional baseball. I've had 2 failures. So I've done 400 with 4 failures that I know of. And the fact that these last. I have a guy in the major leagues right now who was an all-star last year. Okay. I did his UCL in 2012.
Yeah.
And they did an MRI of it and it still looks fine.
Awesome. That's awesome.
So the thing is that I think with this technique, it's going to last longer, and I'm going down to a lab down at Arthrosc to do the cadaveric studies, and even Chris Camp admitted to me, he goes, "Yours is going to be the strongest construct." I said, "I know, because there's nothing else that's going to be as strong as this."
Just is, yeah.
And the data has borne out. Like I said, is that, I've only had 2 failures. Really, and Keith says I really only had 1. He didn't even blame the second failure on me. He says you've only had 1.
That's pretty good. That's pretty. You can't complain about that, can you?
No.
So tell us, just tell us briefly. This wasn't a question I added on, or a question I had on here that we were going to ask you per se. But so can you tell us? Just kind of, can you give us like a quick overview of your rehab for these, and maybe how it might be different than other people's rehab?
So initially, I have them in a posterior molded splint for usually 5 days, 7 days, depending on. Then they're out of the splint. They go into a hinged elbow brace that's full out. I let them full out. I let them go. And they're in that brace for 6 weeks. Okay. And that's the other part. And I've talked to our PT with the Royals. The one thing, our head PT, he's now up on a major league club. He's rehab probably 70 or 75%. I've only had maybe 2 that have been somewhat stiff. And that's the one thing he says about mine. He goes, the one thing we can guarantee, yours aren't going to be stiff. I don't have stiffness problems. Okay. So if it's a pitcher, I will let them start their throwing program at 18 weeks. If it's a position player, I will let them start their throwing program around 16 weeks and their hitting progression at 14 weeks. So the goal is to get the pitchers back at 10 months and get the position players back at 8 months. And that usually occurs. But again, that's depending on the time of the season, right? Because
yeah, sure.
You know, if your 10 months is getting into the fall, then there's no reason for you to rush them back to the fall.
Exactly.
Right.
No reason to rush them.
But they'll have a normal off season, right? They'll have a normal off season and get ready. So it just, but the goal is to get them back, pitchers back at 10, which I've been doing, and position players back at 8.
What do you think what do you think is causing or not causing, but helping with lack of having no one that has stiffness issues, or very rarely someone having issues with stiffness? What do you think is the reason for that?
Well, I get them moving right away. There's some people that'll lock the elbow. They don't do terminal extension, right? They'll wait, you know, a few weeks to get their terminal extension back, and or start terminal extension. It's just like the ACL way back in the day, right? We didn't want terminal extension. Something would happen. Blah 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 blah. I let them go full out. I don't have any issues in terms of that graft failing.
So really, I mean, I was going to ask you questions about complications that you might see. You're not really seeing any complications. You're like, I'm guessing infection rates are like really rare for this.
I've never had one.
None. Ever.
I've never had one.
Good.
Never.
Good.
Now the thing is that
it's awesome.
What we're trying to do is look at like MRIs, like MRI imaging. And I don't know if any of you guys know Pam Lund. She's in Phoenix. And I called Pam, and Pam was like, I think I've only imaged 2 or 3 of your UCLs ever. And that's in 15 years. She said, I don't know if we even we don't have any.
That's really good.
That's my players going to other clubs, not just with the Kansas City Royals. She said, she goes, I can maybe think of 2 or 3 that I've ever imaged, and they were fine. Your graph was fine.
That's awesome.
They had VEO instead of, you know, they thought it was maybe the ligament. I don't know.
So what do these have? You said you had 2 that failed? 2 out of 100 professional guys. And what do you, that's not really, I don't know that's even really worth talking about. I was going to ask you about what you do revisions with, but it's 2. I don't know that it really matters, does it? I mean, that's hardly anything.
And here's the thing. I think with this, it would be an easier revision, right? Because now you have sockets that you're dealing with, right? Unless they broke the socket. I mean, you're just dealing with sockets. So you could take it out, dunk another one in, put it into the humerus. You'd probably have to drill your holes in the back of the humerus again, but you're just dealing with sockets. You're not necessarily dealing, if you're dealing with the docking technique, you're dealing with those 2 holes, trying to find them into the ulna.
Yep.
Now you'd be able to maybe dock it into the humerus, but docking it into the ulna, you still have to re-drill those holes, where I don't think you'd have to do that just having sockets on either side.
Yeah, great point. Great point.
Maybe a dumb question, but assuming your patient has another palmaris longus, you could just use that again on the other side.
Oh, I've done that. Yes. On the revisions of other people that, you know, yeah. I mean, you could use the palmaris on the other side. Absolutely.
Yeah. What do you, if you don't, if your palmaris, do you have instances where the palmaris isn't large enough and you have to go to something else?
I go to the gracilis.
Gracilis.
Okay. I never use allograft. I've never used an allograft ever. Never.
Is allograft done a lot with UCLs?
There's some. I mean, I know of, gosh, I'm blanking on the doc's name that we had in Wilmington, Delaware. He had a series. he said him and Altchek had a series of allografts that they've used, but they never published it.
Oh. And they did okay. They're claiming they did okay.
Well, there were some failures there.
Yeah. You would think. You think it would
Yes.
be higher. Yeah.
Yeah.
Doc, we have people that send in some questions, and we
Yeah.
have one question and one statement. Mark Rosales said, "You're gonna get the Nobel Prize, Doc." So I guess he thinks you're genius for this. Thanks, Mark. And then Joyce Lockhart is asking, do you rehab your throwers that are college different than you do the professional guys? Is there anything
No.
different you do? They do the same? Okay.
Nope.
Exactly the same. Good.
They're the same human being.
They are.
I mean,
you're exactly right.
They're the same human being. I mean, the pro guys, yes. Well, the college guys get daily stuff too, right? I think the difference is, to some degree, is between the high schoolers and the college or pro guys.
Right.
Where the high schoolers are going to the therapist maybe twice a week, 3 times a week, depending on if mom can take them or whatever. But even still, I treat the high school guys like my pro guys. I put them on the same timeline. The other thing that I didn't mention is, now we talk about using the internal brace, doing repairs in an internal brace. I think this technique, you do not need an internal brace. I don't use an internal brace at all. I don't.
Well, yeah, I don't know.
With the third strand, your third strand is your internal brace, but it's a biologic brace.
Is the brace.
If you want to call it that.
Yeah.
I mean, you don't, and the problem with the internal brace has been, how do you tension it? Right? There's some people that tension it in flexion, some people tension it in extension, and the problem has been that these are getting stiff. Some of these elbows using the internal brace are getting stiff.
Does it matter? Would you get stiff in one, like flexion versus extension, if you tighten it in one versus the other? I mean, is it common if you tighten it, and if you, like you said, if you put tension on it, tighten it in flexion, will they get typically lose extension?
It's hard to say,
because you're not doing it. Yeah.
Yeah, I'm not doing it, but we sat in the winter meetings talking about this stuff, whether you tighten it in flexion or extension. I'm like, not my problem. I'm not even worried about it. I'm not worried about it.
Oh, gotcha. Awesome. So Doc, can we go back just a little bit, maybe before you even have to do a reconstruction? So someone comes in with medial elbow pain. What is your history that kind of gives away that you suspect that it's a UCL? Is there like some consistent themes that you almost always hear? Or what are kind of the pearls to your history taking, and maybe even pearls to your physical exam? And while you start to listen to that, I'm gonna go shut my curtain, because people are texting me, giving me shit about like I'm at a disco, or I'm at a disco.
Well, Rob,
or
that's what we were asked. The
Doctor.
panel wanted to ask you
I know.
a question. If you're in a disco right now, or have a Saturday Night Fever going on at your house.
No, it's just the sun. The sun's coming in. So, Doc, go ahead. I'm going to step off.
We'll talk about that. It's funny. We're mentioning people. Meister literally just called me. Anyway, I'm gonna tell him, Mike, what you said too. I'm gonna mention you when I get off the phone.
You do it.
So here's the thing: the UCL, in my opinion, the integrity of the UCL is based on 2 things: command and velocity. Command wise, and I ask them, and that's what I ask. I don't ask them a lot of times. You're not gonna get the typical I felt a pop. Because most of the time, the UCL, there's an attrition of the UCL. Okay, so sometimes you're not going to get that classic pop. If the UCL is pretty good, then you may get it. But it's like I was throwing 95. Now I'm throwing 85. And it's just been getting worse and worse. And I can't bounce back. I'm used to pitching every 5 days. I throw my start, and it takes me 4 days, 5 days to bounce back before I can start again.
Recover. Yep.
So the recovery is longer and longer and longer and longer. Most of the time with the UCL, in terms of them throwing, they usually will leave the ball up because they can't draw down because their flexor is also involved. Okay. So, and I always ask them, I'm like, what do you do for shoulder care? What do you do? And most of them will say the same. I say, and this is what I tell them all the time. What do you do for arm care except for bands?
I'm afraid to even hear your answer. Or your,
And well,
yeah.
and when I say except for bands, then they give me this.
Yeah, deer in the
Because they don't
headlights.
know.
Yeah.
They don't. That's all they know, right? And so those are the big things. I mean, there's not a lot of esoteric stuff here. Now, depending on when they feel the pain, do they feel the pain on ball release? Because most of the time on ball release, you're talking more about VEO than a UCL injury, right?
Yeah, exactly.
They're usually in the early acceleration phase of the throwing cycles, really when they start having issues, right? And so I try to keep it, like I said, I'm from Lexington, Kentucky. I try to keep it simple. So those are the things. So then when I'm examining them, and I have them lay, first I have them sit up for me and I look at their range of motion, and I'll have them with their arms out and their arms up. And as soon as I see that trap go up, I already know there's a problem. Okay, they're gonna have some bad GERD sitting here. I know it's coming, right? And so I'll take their rotator cuff strength and all that, yada yada yada. Then I have them lay down, and then I start looking at their shoulder. He said, "But it's my elbow." I said, "I know." And so I will measure. I measure a total arc on my patients. All my patients, all my throwers, I measure total arc, and I'm usually pretty good in terms of eyeballing it. So I'll go to their affected side, do that. Go to their non-affected side, do that. And most of the time, it's anywhere from probably 25 to 35 degree difference. Most of the time. Okay.
Of total arc.
Total arc.
Yeah, that's a problem.
Okay, that's a problem. It should be
a big
15 degrees. It should be 15 degrees or less.
Yeah,
right.
For sure.
And so that's bad. So then I'll do a bounce test to look for VEO. I'll do a hyperflexion test to look for VEO. And then I do the dynamic and static milking maneuver last. Because once you light them up, then you can't get any of the other stuff.
You're not going to do it again, are you?
It's all over.
So then I do my dynamic where I have them pronated and I lock them up top and I load. And then I do my dynamic milking. Okay. Last thing I do is I have them stand up and face their parents, and I look at their scapula. Now that's Ben Kibler killing me with that. And Ben was my minor league doc in our hometown in Lexington. So I learned a lot from Dr. Kibler.
No doubt.
I look at their scapula, and then I'll sit there and I'll test them. I'll have their arm out with their thumbs down, and I'll have them resist me on their non-dominant side. They're usually strong. On their dominant side, they're weak. Then I'll go in back of them. I'll stabilize their scapula, and I'll do it again. And then they're stronger. And then I said, "Do you know why?" Most of the time they say no. I said, "Good answer. Sit down." and then we move on. Then we move on. You know, whether they have X-rays, do they have an MRI? The thing about an MRI now is that we can get a fever view. Okay, and what a fever view is a dynamic MRI. So now we can stress the ulnar collateral ligament. It's just a piece of the puzzle, but now we can do that. And stress versus non-stressed, if it's 2 millimeters or less, that's good. If it's greater than 2 millimeters and it couples with everything else, then that's telling you that the UCL is failing.
I haven't heard of that. I haven't heard of doing the MRI like that. So that's
yeah. There's not too many. Now Pam Lund, it was Pam, me, and Keith, and a couple of guys, and then blanking on his name, that was with the Diamondbacks. We all sat, you know, Pam was talking about it with us and how to do it. And we finally came up with a way. It was a little device Pam had, and she sent it to all of us. So we do it there at KU. I know Children's here tries to do it. They don't do a very good job, but they try. But it's another way of now, because remember, the UCL is a dynamic. MRI is the static view of a dynamic structure.
Yep.
So now we can get some dynamics going on to kind of look at what it's doing.
So Doc, I want to verify. I heard you say something that I'm pretty sure you said. This is just for my own gratification, but you said you do find throwers have GERD still.
100%.
Yeah. I agree
Very good.
100%. They're not on this panel, but we have experts that are friends of ours that say, I don't hardly ever see that ever anymore. We don't really see it anymore. I feel like I see it all the time. I mean, not literally, I don't
It's
know about
feasible.
100%, but I see it a lot still.
Oh yeah, you see it. I mean, you see it. I mean, they're tight.
Yes.
Their posterior capsules are tight.
Capsule, muscle, something's tight posteriorly.
Yes.
Yeah. And when you
Yes.
treat it, it gets better. Yeah. Okay. Thank
Yes.
you. I just wanted to verify that I heard that right because I
Yes.
agree with you.
Because they eventually get internal impingement, right?
Yes.
Okay.
Yes.
So how do you solve that? That posterior capsule, you stretch it out. Humeral head goes. If it's tight, it's going to go superior and posterior.
Yep.
Right.
Yep.
If you stretch it out, it's going to go anterior and inferior. Give you more space.
That's classic Kibler, Burkhart, and Morgan article. The disabled throwing shoulder, right?
It's country boy common sense.
There you go.
Oh,
You got all
Rob-
kinds
I have to
Rob
say
got-
something. Look, I
Rob
think-
got
Hey,
country
hey.
boy
Here's another
common
one for you,
sense.
Rob.
I
You can
know.
use that one again also.
I know.
Rob.
Hey,
Okay, wait. I got another one for you, Rob. So,
Bring 'em
Doc,
on.
it's funny because he has I don't know if you still do, I think you do, but you have a profile somewhere that's called Scapulicious. But
Oh,
anyway,
yeah,
so
yeah,
he's the
yeah.
scapula dude and gets in all kinds of arguments about the scapula with people. So I was really gratified to hear that you're listening to and following some of the things that we all learned from Ben Kibler, right? And it's like,
Oh.
and even if you don't have a great way of quantifying it, you know when there's a problem. Like when you know, you look at it, it's
Yeah.
like, this is a problem. And then you stabilize it and it isn't a problem. Go figure.
And that's why I stabilize their scapula and let them see for themselves. Right. And I learned that from Ben.
Right.
When we would do physicals during spring training. And
Mhm.
like I always tell them, I get smarter every time I talk to him. I mean, between
I know.
him and Ashley Thomas Bird, those are my two gentlemen of orthopedics. Not to say anything, nothing against Buddy or any of the other guys, because I
Anybody
love Dr.
else,
Salvador
yeah.
too. But those guys are the gentlemen of orthopedics.
Yep.
All right, let's get to some of these questions here. We got a bunch of questions. I was wondering when these were going to start coming in. We went a while before people started filing in
Yeah.
with questions, but we've got some good ones now. Anonymous attendee, who we have no idea who that is, Doc, but they're saying, this is a question for the group during throwing program, bullpen specifically. When is everyone comfortable with the pitcher throwing a max effort pitch? What time frame and criteria is everyone looking for? Do you want to answer it first, Doc, or you want one of us to give a stab at it?
I think here's the thing. My whole thing most of the time is why are we doing max effort throwing anyway?
Well, I think they're saying that, like, when is it okay to do that? I don't think
When is
they're
it
saying
okay?
I don't think they're asking saying to rush it. They're just saying, when do you think it's okay?
If I would probably say if I'm starting them at 18 weeks, 18 weeks, I'd probably say to get them ready for game time, it'd probably be at about 7.5, 8 months.
Yeah. I mean, you have a standard throwing progression you have, right?
Yeah.
So you want them to get through you have a long toss and then you have a pitching progression. So I don't know if you can, I guess you could say 8 months, but really it really doesn't matter because it's going to vary, right? Probably the earliest 8 months. It could be longer if they struggle a little bit with their throwing progression. So
right.
I don't know that I could give a nail down an actual month or weeks.
Because there's some people that are going to get shoulder fatigue too, right? Yep. They get cuff fatigue. Andrews used to build in like 2-3 weeks in this program where they just shut them down, right? Knowing that they were going to get fatigued. I don't do that with my throwing program, but it's variable. But I would say if we're going to go with them being ready at 10 months, 8 months, 7.5, 8 months, I'd let them start throwing max effort.
Okay, perfect. David Shaw, are there any other surgeons utilizing your technique? And if so, are you informed about their outcomes and do they use the same rehab protocol?
There is no one out there that I know that's using my technique.
Just you?
Just me.
Awesome.
That's why people are mad, because it's been 15 years. I haven't published it.
You may be getting a bunch of them starting now after that's published. Yeah, and it's literally just published this year, so
yeah,
it's not like
my fellows are my fellows that did the paper with me. They are so
okay. How long has it been? So how long have they been doing it? Are they like relatively?
No, they were
new
just
fellows?
this year.
Okay,
They were just
so
this
new
year.
fellows.
Yeah, they're new.
A question from Colin Moulton. If you aren't restricting range of motion of the elbow following surgery, what's the purpose of the hinged brace?
I just do it more. I just do it more for protective for the patient.
Okay, just yeah,
I-
more
Could
Slow 'em
could
down a
you
little bit. Yeah.
prophylactically,
mean,
maybe. Yeah.
could you
They
could
don't
you
do anything stupid.
right
Slow 'em
right
down a
it's
little bit.
it's just getting them to understand they had surgery. They're not right. They don't do anything stupid. Yeah, but you could. That's just like people bracing for ACLs versus not. I brace for my ACLs.
Mhm.
Okay, there's some people who don't.
All right. We got a 2-paragraph question from Todd Y that I'm going to skip because I think it would take too long to ask, and I would probably butcher it. So maybe if we have time when we get done, I'll come back to it. Max Mahaffey, is there a time where you would use a double loop instead of a triple loop? So maybe a smaller athlete or a younger athlete?
No.
No.
Except for if I'm doing hamstrings. If I'm doing a gracilis, that the gracilis is too big, when I triple loop it, if it's too big, or a semi-T that's too, a semi-T definitely is usually too big. Because if you do a triple loop on a semi-T, you're almost doing an ACL. I mean, you've got a 9 or 10 millimeter tunnel, right? And so for those, I just do a double loop.
Got it. Todd Y again. I think is this the same Todd Y? He's got like all kinds. Yeah, it's the same Todd Y. I think he's got all kinds of questions. I'm going to ask you this one of Todd's, Doc. How do you load the UCL dynamically for the MRI, like you were talking about? The patient has to be in the tube for 15 to 20 minutes. Is there pain with doing that test and the
It
MRI?
depends on how acute they are. If they're pretty acute, they don't like it, right? It's basically a pillow that's got a rut in it. Now, Pam initially had it where people were putting sandbags there and just letting them they put like it's not like a 10-pound sandbag, but something like a 2.5-pound sandbag
Puts
and letting them lay back.
Yeah.
But now most of the time you can get some opening just from gravity, that gravity valgus, and just let it lay back. You know, I see that when I open it up the elbow, and I do that. I'll let them lay back, and usually when it's bad, you'll get usually 4 to 6 millimeters of opening anyway.
Nice. What's your I don't even know how to pronounce this name, Laertes Cushing? What are your opinions on platelet-rich plasma injections to treat partial UCL tears?
All right, so let's talk about it.
Yeah.
I do them all the time. Okay, so let's start there. I do them. Okay. The theory being, right, it creates an inflammatory response. I think of it like filling in cracks in the sidewall. Okay. So it helps to scar it in. Now, the question with PRP is the scar that you're forming, does it have the tensile strength to do what you're asking for it to do? And no one knows that answer. No one knows that answer. Now, most of the time, you can do it and you can lay down, but the key is you have to fix their kinetic chain anyway, right? Yeah. Most of the time, their kinetic chains suck, right? So if I do a PRP injection, most of the time they're down for about 4 to 6 weeks with a 4 to 6 week throwing program, right? It's going to take about 6 weeks to get your scapula better. It's going to take about 6 weeks to get your posterior capsule better. So you're doing all that stuff at the same time, so that when they come back, they're going to throw better most of the time. And is it because of the PRP, or is it because you fix their kinetic chain?
Yeah. Yeah. And core. You didn't even mention
and the core and their lower half, right?
Yeah.
Yes.
Yep.
Do you avoid another anonymous attendee? Do you avoid shoulder ER or IR for how long? And I'm guessing I guess they're meaning probably range of motion versus doing strengthening.
I don't limit them at all.
So you can go ER, IR as much as they want. How about strengthening, ER, IR?
So the thing is that I do limit, how much, if it's really loading on the elbow too much, and I leave that up to the therapist. If some of that is because it just hurts. They just had surgery, right? Then once that inflammation goes down. But again, I'm confident on my construct. I'm not really as worried. So I push the envelope.
Good, good. Barry Schaefer, my man, Barry, thanks for joining us
Barry.
tonight. We all know Barry, Doc. What other metrics other than time are you looking at to determine progression when they get back to throwing and doing like heavier weights and loaded activities?
Again, their kinetic chain has to be good, right? Their side to side total arc has to be within 15, right? Scapula has to be good. Core has to be good. Again,
It's pretty much anything you'd want any elbow or shoulder patient to be at before they start doing all that stuff, right? I mean, it's not rocket science. It's not drastically different. The same stuff.
It's nothing too esoteric with this. I mean, again, country boy common sense. I mean, if those things are good, then you're taking maximum stress off your reconstruction, right? And if you do that, then your chances of failure go down.
Gotcha.
Everyone gets so caught up on the elbow, they forget everything else a lot of the time.
For sure. Someone's asking for your rehab protocol. Ashley, is that something if Dr. Key could forward to us? Can it be like posted anywhere, or
Yeah,
how
if
does
he's
that?
willing to share it, we can link it in the replay.
Yeah,
I don't have a
Awesome.
problem with that. I can have Kristen or one of somebody send it to you.
Yeah, that'd be great. We'll link
Katie,
it in the
one
replay.
of them. Yeah.
awesome.
That'd be awesome.
For post-op rehab time preferences, what do you typically communicate with your PTs? Do you have your own? You have your own protocol. What is the return to sport criteria? Maybe I think she's meaning, do you have like any certain tests that you other than strength and range of motion? Do you have them do like a shot put thing? Do you have them do any functional tests? No.
I think it's very hard to get myself and Jeff Blum, who's our head PT for the Royals. We've been trying to figure this out, right? And then we finally were like, I just don't think we can figure it out. Is there a true return to play for these? There's not. I mean, you have to go out there when, like I said, we start them at 18 weeks and let them go. And there's not too many stops and starts. Most of the time, as long as you're not introducing something in I say 0 to 100 type of thing, and you're allowing for adaptation of your graft,
Yep.
you're going to be fine.
Perfect. Doc, we're starting, I hate to say this, but this every month, this stuff goes so fast. I mean, it seems like just we get started.
We only have 30 minutes?
No, we're already at an hour. We're almost at an hour already. Yeah, it seems like 30, doesn't it? It goes so fast.
Okay.
And we've only did one of your talks. Tell us quickly what you think about BFR, blood flow restriction training for UCL.
I don't have a problem with it. I don't know if it really helps a lot. My whole thing with that, if it helps, it helps. If it doesn't, it doesn't. I mean, I don't have any sway one way or the other with it.
You're okay if they use it. You're okay if they don't.
Correct.
Yeah.
I have a question.
Yeah.
Okay, so I just want you may have thought about this, never thought about it, or I just want your input from some personal experience with some past people. Thoughts on the spike in lat tears, and do you feel there's any relationship to lat tears in individuals who have had a previous UCL reconstruction?
Well, here's what I'll say about that. I think the lat tears are a little bit of wear and tear over time. I think that's one. Number two is the kinetic chain is so bad that your lat is your decelerator.
Right.
And if it's bad up top, your lat's trying to take the brunt of it because we just throw. And then it's got to fatigue. It's got to fatigue at some point.
Right.
So I think it's more of a constellation of the shoulder stuff not being right. Henceforth, the elbow stuff's not going to be right. Henceforth, your lat is taking the brunt, and you're gonna because most of the time you see in the lat, they're tight as all get out, right? Their total arcs are 30, 35, maybe 40. And then they either blow their lat or they blow out their capsule. One or two.
Ooh.
I've seen in a select few, and this is anecdotal, like a handful of lat injuries that I have personal knowledge of, with 4 out of 5 of them having previous UCL. And I'm like, I wonder if they blew out their UCL, now it's reinforced, now they blow out their lat.
But here's the thing: they haven't fixed the problem.
Right, the
that-
kinetic chain, the root cause.
They haven't
whole
fixed the
thing.
problem that blew out their elbow to begin with. That's why you
That's
have
probably
two-time
right.
offenders in terms
Yeah.
of Tommy John.
Right.
Is that you haven't
Right.
you've scooped out the water, you haven't filled the you haven't in your boat, but you haven't filled the hole.
Yeah. Yeah,
Mhm.
it's interesting.
So
Sorry, I went off
yeah.
topic a little bit, but I
No,
just
that's
had
okay.
to ask
Oh,
an
that's
expert.
good. Good question.
Great topic.
No.
Good question.
So Doc, we're almost out of time, but I got to tell you, this was unbelievable. You got to come back sometime. Would you be willing to come back with us
Yeah,
again? We
I'll
only
come back
did
anytime.
one of your articles. But
If-
you want to go to the you said you wanted to go to ACL next time, right?
I can go to ACL. We can talk that
Yeah.
all day,
Yeah.
every day.
No,
But
we need you back on.
If
I need
anybody
more.
wanted
I
to get a
need
hold
more
of
of
me,
these sayings of yours.
yeah.
The people want more of Dr. Key. Real quick, pitching velocity, return to pre-surgery velocities or close to it in all your professionals.
Do they make it?
Absolutely.
Yeah.
Absolutely.
Yes. I haven't had one that hasn't. I haven't.
Wow.
But like if people want to get a hold of me, and Rob, you can put it out there. I mean, my nurse Kristen, she has a number 913-945-9823. You can call her. You can email me vkey@kumc.edu. You know,
Yeah. If you
I
guys
mean-
didn't get that email address, just send me an email and I'll shoot you Dr.
Yeah.
Key's email.
yeah, it's all good.
Oh,
No, you
there.
have to
mean,
listen to
Ashley
the whole
just put it
thing
on.
again.
Yeah. Ashley just put it on for you.
vkey@kumc.edu, right?
There you go. Yep.
There you go. Y'all better stash it up before I end this session.
Yeah, I feel Hey, I really feel horrible for the masses of people that didn't join us tonight. I mean, this was
I know,
really
they're,
good.
They're lost.
Make sure
Yeah.
everyone
Lost.
shares the replay. I'll get the replay up tonight and posted. Share the replay. And when we have Dr. Key back, we'll have to expand our Zoom capacity for
There you go. Yeah, yeah.
Dr. Key.
Yeah.
It's all good.
Lights out.
Thank you,
All
man.
I can go.
Awesome,
I can go
everyone.
drink my
Thanks.
bourbon. Can I drink my bourbon now?
You should have
You should have been
brought it.
drinking-
To,
you-
yeah, we all got it. You should have brought it.
I know. I was trying to be PC. I just have tea.
Well,
I just have tea. That's all I have.
No,
That's why I
All
put
right.
mine in a hidden cup.
Yeah. All right.
Thanks
Next
for
Journal
joining
Club,
us,
Dr.
everyone.
Key. Next one, you can bring
Thank
your
you
bourbon.
so much.
Thank
All
you
right.
so
You're very
much.
welcome. Anytime.
Good night,
Thanks, guys.
everyone. We'll see you next month.
Take care.